Hello and a warm welcome to today's class. Today I'll be talking about another important exam topic for both undergraduates and postgraduates. I'll be talking about cirrhosis liver. Now, what is cirrhosis of liver? What happens in cirrhosis? In cirrhosis, there is irreversible parenchymal liver injury with architectural damage, fibrosis, and regenerating nodules. Okay, so there is damage to the liver structure, fibrosis, and nodular regeneration. This is the basic change that takes place in the liver in cirrhosis. Now, what are all the causes of cirrhosis? The commonest in our part of the world is ethanol, alcohol. Post-viral, it can be because of hepatitis B, C, D, E, EBV, CMV. All these viruses can cause cirrhosis. Primary biliary cirrhosis, primary sclerosing cholangitis can cause cirrhosis. Autoimmune hepatitis can cause cirrhosis. Another important disease, NAFLD, NASH, especially Indians being very prone for diabetes, that's another important cause. Then you have cardiac cirrhosis, cryptogenic. Certain drugs like methotrexate can cause cirrhosis. Alpha-1 antitrypsin deficiency, Wilson's, hemochromatosis, all these can cause cirrhosis. And also remember hepatic venous obstruction, Budd-Chiari syndrome. Also, cirrhosis can also occur after ileal resection. All these are causes of cirrhosis. What we need to understand is the pathogenesis of cirrhosis, which is very, very important. How does a patient develop cirrhosis? Let's take alcohol, for example. Alcohol being the commonest cause. Let's talk about alcohol. What happens is that alcohol is a solvent for lipid. Alcohol, as you all know, is a solvent for lipid. What it does in the liver is that it dissolves it damages the phospholipid membrane. We may not drink enough alcohol to dissolve the whole phospholipid membrane, but it causes damage and that causes inflammation. The central pathogenesis in cirrhosis is inflammation taking place in the space of DC. Space of DC is the perisinusoidal space. The inflammation takes place basically there in the perisinusoidal space or the space of DC. So I told you alcohol is a solvent for lipid. It affects the phospholipid membrane, causing inflammation. Secondly, when you ingest alcohol is broken down by ADH, alcohol dehydrogenase. Alcohol dehydrogenase is not only present in the liver, it's also in the abdomen. Men will generally have more alcohol dehydrogenase than female. That is the reason why men tolerate alcohol more than women. Okay. So ADH, what ADH, alcohol dehydrogenase will break down alcohol to aldehyde. It takes the help of coenzyme NAD. NAD will be converted to NADH. Alcohol will be converted to aldehyde. Okay. So what is this? This NADH, what it does is it stimulates the Kupffer cells, which is an inflammatory cell. Okay, so that will cause inflammation. It's a macrophage and it will cause inflammation again in the space of DC. If you continue to drink alcohol, NAD will be suppressed. NAD has a lot of function. One important function is gluconeogenesis. Okay, so if you continue to drink alcohol, NAD will be depleted and you will be constantly suppressing gluconeogenesis. So when you suppress gluconeogenesis, what happens? The liver will resort to other method of energy production. So you will have increased free fatty acid synthesis. This free fatty acid will be deposited again in the space of DC, and this free fatty acid will cause inflammation. So that's another method by which there is inflammation in the liver. Again, if you continue to drink alcohol dehydrogenase system will be overwhelmed because you continue to drink, that will be depleted. So the liver will resort to secondary pathway. The secondary pathway will cause free radical injury. Okay, glutathione will be depleted and it will cause free radical injury again in the space of DC. So there is inflammation. The inflammation in the space of DC will stimulate the stellate cell. Stellate cells generally live a boring life of storing vitamin A. It's a quiet cell. Okay, but once it is stimulated, now it's the cornerstone in the pathogenesis of cirrhosis. Once the stellate cell is stimulated, what happens that it produces fibrin, collagen, proteoglycan, all components of dense connective tissue. Okay, so there will be fibrosis in the space of DISI. The space of DISI, the fluid will be replaced by fibrous tissue, fibrous scar. Once this happens, what happens is that the hepatocytes, which derives the nutrients from the space of DISI or the sinusoids, will be deprived of the nutrition because of the fibrous scar. So they will start to die off. This will cause a vicious cycle. So inflammation again will go round and round. And secondly, when the fibrous tissues increase, the sinusoids will become narrow. Okay. So if the sinusoids become narrow, remember Poisson's law, if it becomes narrow, the pressure will increase. So that will cause portal hypertension. Okay. So there are two major things that happen because of cirrhosis. One is the damage to the architecture of the liver, because of which the normal functions of the liver will be affected. Second, there is narrowing of the sinusoids, because of which increased pressure and will cause portal hypertension. These two are important for all the clinical features that manifest in cirrhosis. Okay. What are all the features of cirrhosis? You will have fatigue, you will have anemia. What are all the causes of anemia and cirrhosis? One, there is blood loss. Now, before that, I'll explain what happened in portal hypertension so that you'll understand. What happens when the portal pressure is increased? See, portal vein is a low pressure system. Okay. The liver gets its blood supply from the portal vein and the hepatic artery. The portal vein drains the entire GIT and also the spleen. So once there is portal hypertension, there will be a lot of backflow. Okay. So if there's a backflow, it goes back to the spleen. Spleen gets enlarged, engorged, and becomes enlarged. Again, I told you, the entire GIT is draining into the portal vein, so there will be back pressure. So that will cause ascites and decreased absorption, malabsorption. That will be there. Then, because of the increased pressure, you will have portosystemic shunting. What are all the sites you can have portosystemic shunting? The most important is the lower end of the esophagus, esophagogastric junction, bare area of liver, around the umbilicus caput mellisae, rectum and retroperitoneum. These are all the sites where you can have portosystemic shunting, of which the one in the esophagogastric junction is very important because it can cause life-threatening upper GI bleed. Okay, these are the effects of portal hypertension. So portal hypertension will cause splenomegaly, ascites, esophageal varices, malabsorption. All these are effects of portal hypertension. Then because the liver damage, I told you all the normal functions of the metabolic function of the liver is going to be affected. Carbohydrate, protein, fat metabolism will be affected. Synthetic function is going to be affected. Synthesis of protein, clotting factors will be affected. Storage will be affected. Detoxification of alcohol, drugs, and the nutrients will be affected. See, the portal vein will not only carry deoxygenated blood from the GIT, but it also carries the nutrient from the GIT to the liver. Possible. Okay. As I told you, the portal vein will also carry nutrient, which is not going to enter into the liver because of the portal hypertension. It will get diverted. Also, the toxins that are absorbed will also not be detoxified in the liver, so it will go into the systemic circulation into the brain. That is the cause for hepatic encephalopathy. So there is decreased absorption. 2, there is decreased utilization, and also the toxins are going directly to the brain. These are all the effects. Okay, so you'll have fatigue, anemia. Anemia is caused by hypersplenism, decreased absorption, upper GI bleed, and also alcohol will have a direct suppression of the bone marrow, causing pancytopenia. Okay, you'll have abdominal distension and pedal edema because of fluid volume overload. Ascites you'll have. Then you have jaundice. That at the later stage you'll have jaundice. And remember, cirrhosis can present with any signs of liver cell failure from head to foot, which you all know, or with one of the complications. What are all the complications of cirrhosis? One, portal hypertension, the most important. normal portal pressure is about 5 to 8, and once it goes about 12, the patient will start developing portosystemic shunt. As I told you earlier, it can cause hypersplenism, which results in thrombocytopenia, pancytopenia, anemia. It can cause ascites. Because of ascites, there will be translocation of the bacteria from the gut, and you'll have spontaneous bacterial peritonitis. That's another complication. Varicose bleed, I told you. Esophagogastric junction, you'll have portosystemic shunting, and you can have upper GI bleed, and then congestive gastropathy. All these are complications of portal hypertension. Another complication is hepatic encephalopathy. I told you the hepatic vein is not draining, not going properly into the liver. So, because of the anastomosis, whatever little detoxification in the that's taking place in the liver is not going to take place. So, you will have a direct entry of toxins into the brain. You will have hepatic encephalopathy. Expanding hepatic encephalopathy, there are certain conditions that can trigger hepatic encephalopathy, like large volume paracentesis, high protein diet, upper GI bleed, infection, any electrolyte abnormality, or also drugs which we use like furosemide can cause potassium loss and can trigger hepatic encephalopathy, analgesics, sedatives. All these are causes for or triggers for hepatic encephalopathy. Okay. Then you have hepatorenal syndrome type 1, 2, 3 and 4. What happens is that there is ascites, the compression of the kidney, and the blood flow into the kidney is going to be reduced. So the kidney will start to sympathize with the liver and starts to fail. It is only functional and also not structural. If the patient gets treated for the liver failure or the liver condition properly, the patient will recover. But remember, anybody with hepatorenal syndrome, the prognosis is poor. Okay. Then you have hepatopulmonary syndrome. Again, what happens is, how does the patient present? They'll have dyspnea and deoxygenation on getting up. Okay. They'll feel better on lying down. So they'll have platypnea and orthodeoxia. Okay. These are the features of hepatopulmonary syndrome. Again, this is as a result of nitric oxide release and pulmonary vasodilatation, because of which the oxygenation is going to be reduced. Again, hepatopulmonary syndrome is a dreaded complication, and the prognosis is very, very poor. Then you'll have anemia, I told you, nutritional deficiency, malabsorption, bone complications like osteopenia, osteoporosis will be there. Decreased absorption of vitamin D will cause all these complications. Now coming to investigation. What are all the investigation you do with the in a patient with cirrhosis? Start with the basic blood routine. You'll have to do complete blood count. Here you'll have anemia, thrombocytopenia. And if the patient goes in for spontaneous bacterial peritonitis, that will reflect in the CBC as leukocytosis. Okay. And all the blood routine you need to do, blood glucose will be low because the glucose metabolism is going to be affected, so you'll have hypoglycemia. Urea and creatinine will be elevated if the patient goes in for hepatorenal syndrome. The electrolytes, RFT is important. You'll have dilutional hyponatremia. Okay, you'll have dilutional hyponatremia. LFT full set you'll have to do. Jaundice is a late manifestation, but what is important is the synthetic functions. Okay, you'll have to do complete set of LFT like bilirubin, AST, ALT, alkaline phosphatase. Everything is important. Gamma glutamyl transferase, everything is important. But what is important is synthetic function. Total protein, albumin, globulin. See, all protein except globulin synthesized in the liver. So you'll have hypoalbuminemia and you'll have AG reversal. Any chronic liver disease will cause AG reversal. Secondly, prothrombin time is going to be prolonged because the vitamin K dependent factors are not going to be produced. So you'll have prolonged prothrombin time. So remember, anybody with hypoalbuminemia, prolonged prothrombin time and dilutional hyponatremia, all these are bad prognostic markers. These patients, the prognosis is poor. Okay. After LFT, other special investigation you need to do, because if you don't know the cause, if it is not ethanol induced, if you're thinking of viral hepatitis, you'll have to do viral markers. Okay. Autoimmune hepatitis, IgG. Biliary cirrhosis, you'll have to do IgM anti-mitochondrial antibodies. NASH and NAFLD, you have to do a liver biopsy. Cardiac cirrhosis, an echo will tell you. Okay. Alpha 1 antitrypsin, you can do. And if in a young patient, if you're suspecting Wilson's, do copper and ceruloplasmin. Or if you're suspecting hemochromatosis, you have to do ferritin total iron binding capacity. All these are investigations you need to do if you don't know the cause for cirrhosis. Then you have imaging study. An ultrasound abdomen is enough to tell you whether the patient is having cirrhosis or not. Clinically, what you need to demonstrate is that the patient's liver span should be reduced to make a diagnosis of cirrhosis. The normal liver span is 10 to 12. Okay. How to know what is the liver span clinically? You'll have to percuss. You'll have to percuss. The upper border will be percussable, but because the liver dullness is continuous with the ascitic fluid dullness, unless it is palpable, you will not be able to make out the lower border. So you can percuss the upper border of the liver. For all practical purpose, take the costal margin as the lower border and measure. If the liver span is reduced, then you can make a clinical diagnosis of cirrhosis. The ultrasound abdomen will tell you whether there is any nodule, the nodularity will be seen, and the liver span will be definitely made out in the ultrasound. More important is the fibroscan, which is a more specific test to make out or diagnose cirrhosis. While doing an ultrasound abdomen, also do a portal vein Doppler to see if the patient is having any portal hypertension. An upper GI-scope is mandatory because you'll have to see if the condition of the varices, see if they are about to bleed. You may have to intervene in those cases. Okay. Apart from that, a CT abdomen, HIDA, PIPIDA, anything, MRI, anything can be done if the facilities are available. See, and as I told you, you need to do an echo if you're suspecting cardiac cirrhosis. Okay. Finally, you can do the ascitic inverse invasive test, ascitic fluid analysis. Serum ascites albumin gradient is very important. A SAG ratio more than 1.1 tells you that the patient is having portal hypertension. Okay. One other condition where you can have a SAG ratio more than 1.1 is cardiac cirrhosis. These two conditions you will have a SAG more than 1.1. And apart from this, you can do gram stain, culture, cytology, glucose, amylase, etc. Okay, with the ascitic fluid. Finally, if there is a necessity, you don't have to do a liver biopsy for all patients with cirrhosis. But if there is a necessity, if you want to make a diagnosis of Wilson's or hemochromatosis, you have to do a liver biopsy. How to manage this, a case of cirrhosis? One, if it is because of alcohol, abstinence from alcohol is paramount important. You'll have to ask the patient to stop alcohol. See, ultimately, you're going to take the patient for a transplant. That's the way you can completely reverse the condition. For that, abstinence from alcohol is very, very important. If the patient is going to continue to drink alcohol, there's no point in doing a liver transplant. You'll have to restrict salt to less than 4 grams per day. And because of the volume overload, we can use potassium sparing diuretic. The spironolactone is the preferred drug because it's not only a potassium sparing diuretic, but it's also an aldosterone antagonist. In cirrhosis, you will have hyperaldosteronism, because of which you can use spironolactone and a dose of 100 to a maximum of 400. But remember, aldosterone is not a potent diuretic, so the abdominal distension, pedal edema may not come down with with the spironolactone alone. So you may have to combine it with furosemide. The ratio is 1:4. Okay, a maximum of 160 milligram of Lasix can be used, but always remember there will be potassium loss when we use furosemide, and this is an important precipitating factor for hepatic encephalopathy. So be cautious while using furosemide. Again, this also may not be, both the diuretics also may not be enough to cause the decrease in volume overload. So we may have to resort to therapeutic paracentesis. Okay, remember, while removing ascitic fluid, whether you're removing 500 ml or 5000 ml, always replace it with albumin. Otherwise, the patient can go in for hepatic encephalopathy. Again, albumin replacement is very important. Then prevention and management of complications. What are the complications? Portal hypertension will be there. Portal hypertension, to reduce the portal pressure, one can use beta blockers like propranolol, metoprolol. Okay. If the patient is having an active bleed, if the patient comes to you with an acute upper gastrointestinal bleed, what are we supposed to do? Stabilize the patient first. Give them fluids, replace blood, and once the patient is stable, take the patient for an urgent endoscopy. If there is a bleeding varices, you will have to do sclerotherapy initially. Okay. In the meantime, we can do medical management with terlipressin and octreotide. Okay. So first sclerotherapy is done, and if the patient bleeds for the second time, we can repeat sclerotherapy. If the patient bleeds for the third time, we can resort to other methods like Seng's tube or balloon tamponade. And still, if the patient continues to bleed, we'll have to do TIPS. By doing TIPS, what we are doing is we are not going to improve the prognosis in any way. Transjugular intrahepatic portosystemic shunt will shunt the blood away from the liver into the systemic circulation. So what happens? Whatever little detoxification that is taking place in the liver is not going to take place. So the patient will be prone for hepatic encephalopathy. Okay, that's how we manage upper GI bleed. Hepatic encephalopathy. How do you manage hepatic encephalopathy? First, think of the precipitating factors. Is there any infection? Are we using any offending drug? Are we tapping too much of ascitic fluid? Excess protein diet? So, upper GI bleed. Think of the precipitating factor and treat that first. Secondly, we can use lactulose and then gut sterilizers like rifaximin. Initially, we used to give them neomycin because of toxicity. Now we use rifaximin. Okay. Hepatorenal syndrome, again, albumin will help, or MAS therapy, molecular absorbent recirculating system, like how we dialyze the kidney, we dialyze the liver. So what we are doing is we are buying time by doing MAS therapy or giving albumin. We are buying time so that the patient recovers and we can take the patient for a transplant. Hepatopulmonary syndrome, there is nothing much we can do. I mean, the prognosis is very poor. Another important complication which I missed here is malignant transformation. See, I told you the patient will have a shrunken liver. So on examination, the liver will generally not be palpable in a patient with cirrhosis. Patient came to you 6 months earlier and the liver is not palpable. Now patient comes to you with a palpable hard liver. Always think of a hepatocellular carcinoma or malignant transformation. And also, alpha fetoprotein has to be done every 6 months to see if the patient is going in for many malignant transformation. Okay. Then you have spontaneous bacterial peritonitis. How to treat that? When you suspect any patient coming to you, any patient with cirrhosis comes to you with abdominal pain and fever, always think of spontaneous bacterial peritonitis. Do an ascitic fluid analysis. If you have more than 250 cells, the diagnosis is confirmed. Treat them with third generation cephalosporins. Once you treated that, you will have to give prophylaxis with quinolones lifelong. Okay. As I told you, ultimately your aim is to take the patient for liver transplantation. That is the definitive treatment for cirrhosis of liver. I hope this class was useful for you. Thank you. Okay, Anna.